started about 12 years ago. It was the idea of, gentleman right over there, Victor, if you could kindly stand up, our founder. For those of who you may not know Victor, he is one of the pioneers in neuro-oncology. I won't call him one of our fathers, but certainly a pioneer. And he had the vision to see that neuro-oncology is a
medulloblastoma tumors started in different cells in the brain. And the tumors that came out were different. And we've always wondered why different people's tumors are different, why some tumors respond to chemotherapy, why some don't. And perhaps what David's results will support is not only is it the mutations that are driving the tumor, but it's the fact that different tumors have started in different cells. And that origin they come from is part of the reason why the biology is different. Next talk was done by Paul Northcott, who's from my lab in Toronto. He presented a paper where he's looked at the mutations in a series of over 200 medulloblastomas using a novel technology called SNP array mapping. So as cancer biologists, we like to find areas of the DNA that have been gained or lost. So those are mutations. If we can understand the mutations that drive cancer, those are the things that make a cancer cell different from a normal cell. Maybe we could fix that cell or kill it. In the past, when we wanted to find an area of a chromosome that was deleted, it had to be the size of 10 to 20 million base pairs in size. So that's 10 to 20 million letters. Now we can see deletions that are only 5,000 letters. So in just a couple of years, we've been able to see by orders of magnitude much better the mutations that are occurring. One of the things that's unfortunate that Paul also identified was that the genetics of medulloblastoma are very heterogeneous. So there are probably many, many different types of medulloblastoma, and as a result, developing therapy for it is going to be that much more difficult. Hai Yan's graduate student from Duke University presented a nice paper on a new cancer gene, or oncogene, called OTX2. OTX2 is a gene that's normally involved in the development of the brain. In medulloblastomas, what happens is the tumor gets too many copies of the gene. It's like it acquires 10 gas pedals instead of having one gas pedal. As a result, the cells grow too quickly. What's very interesting is, though, these medulloblastomas that do have amplification of the OTX2 gene are sensitive to treatment with retinoic acid, which Hai Yan put very nicely. And in fact, treatment with retinoic acid is going to be on our next COG, which is the Children's Oncology Group high-risk medulloblastoma protocol. So we have a nice example here where somebody's discovered something in the lab, and now it's going forward into the clinic to hopefully provide better treatment for children. Tracy Ann Reed, who's from Rob Weck-Larea's lab, also at Duke University, presented some work on cancer stem cells from a mouse model of medulloblastoma. So this is not the stem cells that you hear about on the news where people are going to cure Parkinson's or anything like that. These do not come from fetuses. These are cells from within a tumor that are able to divide an infinite number of times. Most of the cells in a tumor can't do that. They can only divide a limited number of times. So it's very important to identify these cancer stem cells because those are the cells that we need to be killing. Those are the bad guys. What Tracy Ann and Robert already showed was that they could identify from this mouse model the cancer stem cells. And interestingly, the markers for cancer stem cells in mouse are different from the ones in human, which is very important. Bill Weiss, also from the University of California, San Francisco, presented another mouse model of medulloblastoma. And he did that by making the mice express too much of this gene called NMIC. NMIC is another one of these gas pedal genes that normally makes the cells divide. But again, if you have too much of a good thing, you get cancer. What's really nice about this mouse that Bill Weiss made is that he can actually turn on and off the expression of NMIC by putting a drug in the mouse's water. So he can turn the gene on, cause a medulloblastoma, and then turn the gene off and see if it goes away. Or he can turn the gene on and try and look very, very early to see what happens in the very early stages of medulloblastoma. This is a very powerful tool that he's going to be able to use to study medulloblastoma biology. Annie Wang, who's from our shop in Toronto, presented a paper looking at supratentorial PNETs, which is a tumor that's very closely related to medulloblastoma, but instead of occurring in the back of the brain, the cerebellum occurs in the top of the brain. They look the same under the microscope, but genetically they're very different. What Annie showed us on Friday was that, in fact, there are multiple groups of PNETs as well. So these are not all the same. It's not all Volkswagens. It's Volkswagen for all those Chevys and whatever else. And that's, again, going to be very important for treatment because you can't expect Volvo parts to work in a Volkswagen, right? We're going to have to sort out these various tumors. She also outlined for us a pathway, one of these molecular pathways that David was talking about, that is systematically mutated syndrome diagnosed, which she's developed a piece of DNA that jumps around the genome only in the brain cells and causes havoc in the genome and the chromosomes, turning genes on, turning genes off, and you get medulloblastoma. What we think is very important about this too is that if you think about it, most of the children that are dying from medulloblastoma are dying from metastatic disease, so they're dying from medulloblastoma that's spread. In the past, most of the labs that study medulloblastoma, including my own, we've all been studying the lump. I'm a surgeon, I can take the lump out. The lump is not the problem, it's the metastases. And our new model actually has the exact same pattern of metastases that you see in children. And we can actually track quite easily where this little sucker has jumped around in the chromosomes and figure out what the genes are that cause the tumor to spread. So in conclusion, what did we learn from these various talks over the last couple of days? Whereas most models a few years ago were more to prove the role of these genes and prove that these genes that were mutated really do cause cancer, we now have much more sophisticated mouse models that we can use as tools to study the cancers and to learn about the human disease. Most of the talks in the pediatric microbiology portion of the meeting were about medulloblastoma. I think that's probably because it's the most common tumor, but it's also because we understand a lot about how the normal human development goes awry and it leads to medulloblastoma. Unfortunately, there aren't nearly as many talks on things like adenoma or pediatric gliomas. There are some wonderful new tools to find mutations in cancer, as shown by Dr. Plang's lab and my lab, so that such that we can see things at 100 to 1,000 times the resolution we could just a few years ago. And goodness only knows what we're going to be able to see in the next couple of years. Unfortunately, from a couple of the papers that we've seen, that a number of these tumors are very heterogeneous. There are all those Volkswagen, Chevys, Fords, and Mercedes. And in fact, as a result, we're probably going to need multiple different treatments, or as I like to call them, tailored treatment, to be able to treat them.
So, as you know, the current management of brain tumors is surgery for diagnosis and helping management. And Fred is going to answer that both in adults and pediatrics. Then we're going to hear from medicine in terms of chemotherapy, and then radiation as the third foundation, and of course the biological therapies, the additional therapies that's going to come and has come to science. So it's a multifaceted modality of therapy, and Fred's going to talk about surgery.
Well, thank you very much. I'm honored to be asked to speak in front of you all. Surgery is a very important part of the treatment of brain tumors, and I think that there's been many advances in surgery. So what I thought I would do is sort of give you some broad perspective on the advances over the last couple of years, and then focus in on some of the papers that were presented here that support or further those areas of advancement. And I think there's been sort of these 5 areas of advancement shown here: advances in surgical technique, better understanding of the impact on surgery on outcome. There's also been an increase in the development of what I would call surgical-based therapies, where the surgery is actually part of the therapy, and you'll see some of those. And then the ability of surgeons to contribute to medical clinical trials of drugs. And then there's been advances in what I would call issues surrounding surgery. So what do I mean by all of these? Well, one of the biggest things that's been happening in surgery is a dramatic improvement in our ability to precisely and accurately and safely take out brain tumors. When I first started this back in the early 1980s, the morbidity, or the mortality actually, from a person who had a tumor removed from their posterior fossa, from their cerebellum, approached 30%, and now it's less than 1%. If you had a large acoustic neuroma, which is a common thing that I saw when I was a resident, we were battling to get the tumor out, and most of the patients had weakness in their face for this benign tumor. Now, we're finding the tumor early, and we're trying to preserve hearing, not only trying to preserve the face. So there's been a complete shift in what our expectations are and what we can do. And the things that have caused that, the biggest revolution that caused that, was the development of the microscope. We could see things better, we get good lighting, and with that came a better understanding of the brain. So now we could go through different pathways to the brain, through the sulci and the grooves within the brain rather than actually going through the brain. And that was a major advance. The second revolution that happened was the use of image-guided surgery, marrying the ability to do an MRI scan with computers so that now we could use all of this technology to guide us directly to a tumor if it was deep in the brain, or to find the edges of the tumor to better know where the tumor was in the brain. And that is added to intraoperative ultrasound and then to the ability to functionally map the brain in the patient so we can find out where the speech area is, we can find out where the movement areas, we can avoid those areas when we're doing surgery. So with that sort of background, there's several papers that have addressed surgical technique. And I think the first paper that was presented here is actually a poster. It's so new that it hasn't even been realized to be that innovative. And the idea is to use endoscopes for surgical resection of tumors. Now, there's certain tumors, particularly this might be very effective in some pediatric tumors that are suprasellar craniopharyngiomas that occur near the eyes. Surgeons now are actually going through the nose using small endoscopes, not making incisions, to take some of these tumors out. It's very early on in the development. There's still a lot of problems that have related to doing them, but clearly this is going to probably be the standard of care in 5 to 10 years. That technology has now been shifted to taking out primary tumors in the brain. The endoscope would allow you maybe to do two small burr holes and take a tumor out. How that's going to actually evolve is not clear. Is it even possible? But these investigators from Pittsburgh are actually starting to do that, and they're showing that that actually might be a feasible way to do it. So that's, I think, is something that's right on the horizon and is potentially a major advance in surgery. The other papers that we were presented had to do with cortical mapping and subcortical mapping. In other words, figuring out what the pathways are in the brain that are subserving movement or speech and trying to avoid them during the surgery. The other thing that's been a major improvement in surgical technique is the use of awake craniotomy. Anesthesia has actually made surgery much better. The anesthesiologists today have really improved their techniques. And many of the cases that we do now, we do awake, which is important because what does the brain do? Well, the brain thinks, it functions, it produces consciousness. So if the patient's awake while you're operating, you can preserve all those things you need to preserve. And an awake craniotomy has really become a very common way of doing cases. In fact, in our institution, almost 80% of our cases are done with an awake craniotomy where the patient is actually talking to us. So those are some of the advances in surgical technique. Another thing that's happened in the last couple of years has been a better understanding of the value of surgery. So we've always known that for certain tumors like pilocytic astrocytomas or craniopharyngiomas or gangliogliomas, we can actually cure many of these tumors with surgery. But there's always been a big debate, does surgery actually impact the outcome of a person with an infiltrated tumor like a fibrillary astrocytoma or an anaplastic astrocytoma or a glioblastoma? Well, in the last 5 years, there's been there's been an increasing number of papers really trying to show statistically that we are making an impact. Our group actually published a paper of over 400 patients proving that the more tumor we could take out in patients with glioblastoma, the better off the patient was going to be in terms of their survival, not just in terms of getting them through the early part of the disease. And there was a very important paper published here from the UCSF group showing that that same effect in the high-grade glioblastoma was actually seen in low-grade tumors, the grade 2 astrocytomas. In other words, the more tumor you could take out, actually that translated into a better survival for the patient. So that gives us more impetus to use the surgical techniques we have to take out as much tumor as we can, as accurately as we can, while at the same time preserving function, pushing the envelope to try to take out as much tumor without hurting the patient, which is ultimately the goal. So I think that was a very critical paper in terms of the value of surgery on outcome. The other thing that's been developing is surgeons have become increasingly involved in the treatment of patients with glioblastoma or other gliomas. We used to take the tumor out and then send the patient to the oncologist and hope they could come up with a radiation oncologist and hope that the radiation and the chemotherapy work. But now surgeons are actually developing ways that in surgery we can impact the outcome. One of the first was the development of Gliotel, which was the BCNU wafers that we could put in the tumor to try to help to decrease the growth of the infiltrating portion of the tumor. And there's been several new techniques that surgeons are developing. One of the most critical is the second two papers here called convection-enhanced delivery, in which we put catheters in the brain and then deliver the drugs directly into the brain through these catheters. Unfortunately, the second paper on this results of the PRECISE trial, which was actually a large phase 3 randomized trial comparing the use of this drug which was an endotoxin delivered by convection-enhanced delivery to gliadel wafers, proved that there was no difference, unfortunately. But I think this was the first trial where we were trying to do this convection-enhanced delivery, and this is an initial step in the development of this approach. The other thing that surgeons are doing is using gene therapy, which they have to inject into the brain, or viral therapy. And there's also going to be a report tomorrow on the outcome of using an adenovirus, which contains the TK gene, to deliver to the patient. So these are local delivery methods that surgeons are using to try to control that infiltrating tumor that they can't take out. And I think these developments have been critical and continue to be new areas of growth. The other thing that surgeons are doing increasingly and of increasing importance is we're getting more and more involved in clinical trials. We used to leave all of the medical clinical trials to the neuro-oncologist. The neuro-oncologist gives a drug to a patient, they see how the patient does. The problem with those trials is that no one ever examines the tumor. No one ever figures out, did the drug get into the tumor? Did the drug hit the target? That's becoming increasingly relevant with drugs where we now have that can inhibit a specific target, part of the alphabet soup. We have a drug that can inhibit epidermal growth factor receptor. Well, when you, as a patient, take that drug, did it get in your tumor? Did it inhibit the target? Well, new clinical trials are being developed with the help of neurosurgeons in which the tissue, after the patient gets that drug, is taken out, and we examine that tissue to see if the drug's in the tumor, did it cross the blood-brain barrier, and did it in fact hit the target. And there's a very nice paper here from Mark Gilbert looking at selingitide, which was given intravenously before the surgery, and then they looked to see what's the concentration of that drug inside the tumor, and they actually were able to successfully carry that trial out and show that the drug was actually in the tumor. So these kind of trials we need to push more and more to do so that we can really find out what we're doing when we're giving drugs to patients, and not just check to see if they get sick stomach or if you're getting a rash or something. We need to learn about the tumor. And then the last thing that's been advanced is the issues surrounding surgery. What does that mean? Well, there's been always little questions about whether we should be giving everyone anticonvulsants, for example. Many of you might have gotten anticonvulsants just because you had the surgery. Well, do we really have to do that? So now people are starting to look at those issues. And there was a paper on the use of this prophylactic perioperative anti-epileptics showing that maybe you really don't need to give every patient that. There's also, for patients with metastasis, the issue of whether after surgery, we need to do adjuvant therapy such as whole brain radiation therapy. And there was a paper describing whether everyone with metastases to the brain needs to get whole brain radiation therapy after their metastasis was removed. So these are ancillary things that surgeons don't necessarily do themselves, but consider when they're doing an operation. So with that, I think those are the major advances that are happening. There's a lot more stuff out there that's advances in surgery, but these are sort of the highlights. And I want to leave by giving everyone here a challenge. I know there's advocates for the patients here, and I've been to several meetings, and many of the advocates always come and speak and say, oh, we need to be doing more as clinicians. Well, I'd like to also give the advocates a challenge. I'd like to tell them that one of the big problems we're having is getting patients on clinical trials. At MD Anderson, where we have a lot of trials, it turns out about 10 to 15% of our patients actually go on clinical trials. Many of them don't want to enter clinical trials, particularly randomized trials, where they might get a new therapy compared to an old therapy. And I think if we're going to make a difference, we need to start encouraging patients to at least seriously think about that and not be afraid to enter those clinical trials, because they're the real way we're going to get answers to this disease. So thank you very much.
Thanks, Fred. Fred is our Vice President-elect, and next we have the President-elect of our society, Professor Susan Chang, who's a medical neuro-oncologist from UCSF. Susan.
Thank you, Adam, and welcome to everyone to the public summary session. What I want to review is really an overview of clinical research in neuro-oncology from the medical perspective. You've heard the wonderful advances we're making with both the basic science and mouse models and trying to understand the biology. So how to ultimately translate that back to the patient. And this is basically a review of the types of clinical research that's been presented here at the meeting today and over the last few days. When I think of clinical research, you can think about it in terms that's where you have the therapeutic trials. And these are classically phase 1, 2, and 3 trials. So a lot of the work that's presented today are highlighting the results of those trials. And it's really impossible to go over all the results of those. And I'm going to try to highlight the ones that I think we have to look forward to in terms of the horizons. So the phase 1 and 2 trials are really where we're trying to improve on specific aspects of patient outcome. For example, the time it takes for the tumor to grow, or how long patients survive. We're also obviously interested in what is it going to do for the patient in terms of side effects. And so the very early trials, the phase 1 trials, really address what are the toxicities, what's the right dosing that we should use for patients. So a lot of the studies that have been reviewed here at the meeting is results of very early trials in terms of how safe it is to give to patients. But I want to highlight that to really look at advances in neuro-oncology, we have to look at the non-therapeutic trials as well. These include important things like neuroepidemiology. So what it is that triggers these tumors to form in the first place. Most of the times patients come in and there's not a history of a family history of brain tumors. These are fairly sporadic. And it's very scary to think, well, is there something in the environment? What about my children? Or what about my spouse and other people in my family who may be potentially at risk? So trying to understand on a population-based level what the risks are is really critical so that we can understand perhaps how these tumors form in the first place, what are some of the triggers that may cause these tumors to form. And so there's a lot of work going on in neuroepidemiology work to try to understand that. Similarly, neuroimaging. So even though this is not something that is therapeutically driven, it's really important to try to understand how these tumors grow and what it is that the imaging tells us. So if you look at neuroimaging research, a lot of the highlights yesterday at the neuroimaging session was really on some of the novel techniques that we're using to better understand the brain and what it is that this information is telling us. I don't have a pointer here, so I'm going to walk across the room here. But the standard scans that we use is the MRI scan here. And this is, you can see here on that scan, where we're just looking at anatomy. And we also look at whether these tumors allow the blood-brain barrier, which is normally kept intact in the normal brain, whether there's any leakage. So when you have something in the brain that irritates the brain, you get this leakage and you get a lot of swelling. And you see that on that particular scan. But there are other ways to look at the brain. We can look at the function of the brain. We can look at whether these tumors, these areas are taking up a lot of sugar, for example, and that's what a PET scan does, and that's the one on your far right-hand side. And then we can also look at the types of water, the way the water transit within the brain tissue. And that's a specific type of scan called the diffusion-weighted imaging. We can also look at perfusion. So we've heard that these tumors bring a lot of blood vessels into them to try to feed them. That's important for us to be able to visualize because a lot of our therapies are targeted to this particular pathway. And so trying to understand how much blood is actually going into the tumor gives us a better understanding of the effects of our therapies potentially. The last picture here on this slide shows what we call spectroscopy. And there are many institutions that are doing spectroscopy, so you may have heard of this. And what is it exactly? Well, what it is really a chemical fingerprint analysis of the tumor as opposed to the normal brain. So within the tissues, there's normal levels of different chemicals. And you can see that on the scan here where you see the different peaks and levels. And each of those peaks represents a certain chemical. And tumors have a different proportion of different chemicals than normal brain. So we can characterize the tumor in terms of its biology, in terms of what's actually making up the tumor in terms of the metabolic aspect. Probably one of the more exciting, I think, scans that were, data that was presented was one that you can see here. That's this one. The normal types of scans that are done in terms of MRI is done on a 3 Tesla. Tesla is a measure of the magnitude of the magnet. How strong is the magnet? And that scan is actually done on a 7 Tesla research scanner. And this is showing us the blood vessels that you can see. And it's basically almost like an anatomy textbook in terms of the details, the characterization. And so what we're finding out is that with this particular type of scan, we can see the effects on the normal brain that, for example, radiation might have and chemotherapy might have. And this is important for us to try to link some of these findings to some of the quality of life types of effects of our treatments on patients. For example, how are we able to think? What about our memory? What about our language, multitasking? all the things that are difficult sometimes after we have successful therapy for our patients in terms of things like radiation or chemotherapy. So better understanding some of these markers is going to help us to guide how we evaluate our patients and also how we determine the response of our treatments to patients. Now we've heard about the alphabet soup, and what I put on here is just a schema of one pathway. And this is the epidermal growth factor receptor pathway. As Ab mentioned, we're now moving forward from not only radiation and standard chemotherapies, which are drugs that affect dividing cells, and probably you're familiar with a drug called temozolomide or Timidar, which is now the standard in conjunction with radiation therapy for newly diagnosed glioblastoma. So what we're trying to do is build on that. And by understanding the biology of these tumors, understanding the pathways that are disrupted and that are important for growth mechanisms, we can try to target. And so this is one pathway that has been targeted in neuro-oncology. There are several papers looking at various of these agents. You can see there the names of the drugs that are being used in combination with other standard chemotherapy and standard radiation. And this is where I think you're going to see most of the progress is going, is the combination of these very exciting novel agents with the standard treatments that we have available. So this multimodality approach is really critical. The other drug, and this has been very exciting, is bevacizumab. And this is an antibody that tracks or attacks a specific pathway, which is the vascular endothelial growth factor pathway. And the vascular endothelial growth factor is important. That pathway is important for this angiogenesis component. So these tumors take up, they drive, this whole process gets upregulated. You can see blood vessels coming into the tumor. And that's a hallmark of glioblastoma. And this particular drug, in combination with standard chemotherapies, have been looked at. There are a number of publications. One just came out about a few weeks ago in our Journal of Clinical Oncology. And if you look through the abstract book, I found approximately 10 clinical trials that are talking about either the effects of this drug in terms of the amazing response rates that are seen, as well as improvements in the what we call the 6-month progression-free survival, which is a hallmark of how our patients are doing, but also about side effects, what to expect in terms of how to dose it, and what sort of complications that might occur. So this particular drug is one that I think you're going to hear a lot about, but also just keep in mind this pathway, because now there are other drugs that are being developed that attack this pathway. They're not bevacizumab, but they work on different aspects of this pathway. And we're seeing those in terms of growth factors. There are pills that can be taken for patients. There's a number of ongoing clinical trials that are evaluating those strategies. This is the kind of responses that we're seeing. This was just published, as I mentioned, a few weeks ago in the Journal of Clinical Oncology, and a lot of this information is actually presented at this meeting as well. And you can see the before on the left and the after pictures in terms of the kinds of responses that we're seeing after we give this particular drug in combination with CPT-11, which is another chemotherapy drug. So it's really great that we're seeing these kinds of responses. In addition to these dramatic responses is an improvement in the swelling or the edema that occurs, an improvement in patients functioning for a period of time. And so I think that one of the things that has been highlighted this meeting is quality of life, and how do we track how patients are doing, not only looking at physically how they're doing in terms of strength and coordination and what's happening on the MRI scans, but how are they doing in terms of their functioning of day-to-day life. So this is another example of the types of responses that can be seen. And this is, again, another drug that targets the vascular endothelial growth factor pathway. And what's interesting about the scans, if you look at the timing for these scans, this is a 24-hour scan. So day 1, 24 hours later after giving the drug, that's what you see on the scan the day after the drug is given. And so this aspect of blocking this part of very blood vessel disruption and the blood-brain barrier disruption that we're seeing, these drugs definitely work on that pathway, because we don't expect that a tumor is going to dramatically improve. Now what that means for me as a doctor looking after patients is that how do we put that in the context of what's really happening to the tumor? So this we may see as a wonderful response. This will probably be associated with improvement in how a patient is doing. But are we attacking the tumor itself? And that's where some of this novel imaging in conjunction with these novel agents are going to get us forward and get us to better understand the effects of therapies for our patients. So I just want to highlight again that this type of work is critical, that you can see what it takes for us to look after patients. We have the involvement of all of these disciplines. They're all represented here at this meeting, and this is a wonderful time for us to be able to get together every year, share what we've learned, friendships, collaborations, and also to be able to provide to you some of the highlights for the meeting. Thank you very much.
Thank you very much, Susan. So before Professor Mark Kieran from Harvard starts talking about pediatric tumors, I just want to acknowledge that any society such as this requires administration, all the hard work that goes in enabling us to do what we do. And that's the patients, our membership, but we have a very solid administrative core. I'd like to recognize Chaz Haynes, who's our executive director. Chaz, if you could kindly stand up. Chaz is headed by two other folks who are not here. Jan Eisenwein, who's been here since the beginning of our society, and then they're here. And they're very, very pivotal in enabling us to do our jobs. So next, Mark Kieran from Dana-Farber.
Thank you very much. So I'm going to take a somewhat similar approach to the last speaker in terms of highlighting what I think are some of the changes. What I've done is broken it up into some of the changes that have occurred over the last year that weren't specifically reported at this meeting, but have been reported in prior meetings. Since in pediatrics, where there are only about 2,000 brain tumors per year, compared to about 100,000 in adults, and a lot of metastases and others primary. In pediatrics, because the numbers are small, the studies take longer, and therefore we don't have the ability to kind of do studies over a short period of time. It's important to kind of know where we have been, and some of what I'm going to tell you is not so much what we have learned to move forward, but what we have realized we're doing wrong, and therefore how to change direction, which sometimes is as important as actually getting a particular answer. So the first, I'm just going to break these up by kind of the standard tumor types that we see in pediatrics. Unlike adults, where the vast majority of the tumors are a single type, and therefore the effort focuses on that, pediatric tumors are just this kind of mix of everything. So we don't have a predominant type, and therefore it's important that we work on all of them. The malignant gliomas that you've heard the adults focus on, in fact, we follow the adults, and much like the adults, we haven't made nearly the kind of progress that we would hope. We have a lot to go here. We recognize from a biologic point of view that the pediatric brain tumor malignant gliomas are fundamentally different from the adult ones in a number of pathways. They share other ones, so although we are going to guide each other, we are not going to be able to just follow them blindly. And in fact, the national strategy for pediatric malignant gliomas, the major advances over the last couple development of 2 new consortia that are specifically designed to begin to study these tumors in pediatrics. For the last 30 years, when you wanted to study a pediatric low-grade glioma, you studied an adult low-grade glioma and assumed they were the same, and we have realized that they are completely different tumors that share virtually no properties whatsoever. And just the ability to now separate them out and study them separately is, I think, going to make a huge effort, both with respect to the NF1, this is a genetic disease where low-grade gliomas are very, very common, about 15% of those patients, and as well as this multi-institutional pediatric low-grade glioma program, of which there are members here. And we'll talk about the last point. And there were 2 papers here, and interestingly, they both focused on the outcome. And as you heard previously, the major finding of both of these studies on pediatric low-grade gliomas, and particularly the latter one, was that if you take patients who can be cured just with surgery alone, because these are low-grade tumors, if you can get them all out, you can actually cure those patients. And you begin to do the neurocognitive, the neurodevelopmental analysis of these kids, they have significant problems in a range of areas. So the kids that are the lucky ones, the survivors who had surgery only, didn't need radiation, didn't need chemotherapy, in fact, weren't as lucky as we thought. We're going to have to build a lot in. It also means that with surgery, we have to find ways of sparing the tissue. And Susan told you about some of those with respect to novel imaging techniques that we can perhaps use during those procedures. And then the major tumor is ependymoma. This is a tumor where we, through a number of reports, both at this and prior meetings, have finally come to the realization that although this is a tumor that cannot be cured with radiation, with chemotherapy, it turns out that chemotherapy can shrink many of these down so that surgeons can go back in and get them all out. Radiation can be to a much smaller area so that they can be cured with a much better quality of life. And again, sometimes just knowing what to do and what not to do become important components. The other thing is due to the rarity of these tumors, for the first time ever, there's now a new international group where all children around the world are going to be treated on a single randomized protocol with this disease in a way to try and improve benefit and nationalize and standardize the approach around the world. For the neural tumors, you heard medulloblastoma is certainly one that has been highly studied. Here was another one of those things that over the multiple reports, including a couple of this meeting, where people have begun to realize that medulloblastoma is not a single disease. In fact, I'd like to think that we figured it out almost before the biologists did. We knew that there were groups with certain types of appearance of their medulloblastoma that appeared to behave differently. And in fact, the national groups have now understood that if you treat them as a single group, some will not do well. You will overtreat some, you will undertreat others. So all kids being treated with medulloblastoma now are divided either into the anaplastic or large cell type, which need more therapy, into the standard type, which gets the standard therapy, or this nodular desmoplastic, which is getting less therapy, which means you can cure them without doing as much damage. And being able to do that are important factors for moving forward. There were 2 papers presented in relapse disease, and it's interesting that they came to virtually opposite conclusions. One of them figured out that if you can transplant these patients after relapse, you can still cure them. The other one found out that if you tried to transplant them after relapse, you in fact could not really cure them. So clearly we still have some things to settle out. Whether this depends on the type of disease or the type of treatment, the chemotherapy used, we have still to figure out. And then finally, the last tumor, which a couple of years ago, I stood up here, in fact, for many places, and I still get some calls from smaller centers that counsel parents not to try and treat children with this disease called atypical teratoid rhabdoid tumor, or ATRT. It's so highly malignant, there's no point. The median survival is often around 5 months. And what has come out of this meeting and others is that, first of all, it looks a lot like medulloblastoma, but it's not. It's much tougher to treat. But that, in fact, with a number of clinical trials done in the United States that were reported previously at this meeting, as well as 2 additional reports that kind of added to this here, the cure rates for this disease, just within the last 5 years or so, are now in and around the 50% plus range. And the biggest thing is to get the news out to families. If your oncologist tells you not to treat, get a new oncologist, you need to go to a bigger center that can apply some of these new therapies. And then the last one is choroid plexus carcinoma. And choroid plexus carcinoma, this is a disease almost solely of infants, so often in the 1 to German group on this study that they ran through Europe, in which they reclassified the disease, randomized the treatments, and came up with really what are probably the best results for this disease that have ever been reported in a patient population measured in the hundreds, so with some validity to the results. But I think the North American group is going to be responsible for picking up and moving forward with. But that kind of advance that was done here yesterday, I think are the kinds of things that we look forward to. And I think that was my last. I'll stop there. Thank you.
13 was something that we had some hope would be helpful for patients with breast cancer with brain metastasis, would improve their outcome with whole radiation therapy. But unfortunately, this large phase 3 study was actually negative. But it is important to know if these things are working or not working. And this was actually a negative study. And last was spinal cord. Spinal cord astrocytoma is a very rare tumor. There hasn't been much study in this because this has been a very rare tumor. But looking at the Mayo Clinic experience, we found that radiation therapy does have a significant benefit for those patients with infiltrated tumors. No benefit for the positive tumors, but for the infiltrated tumors does seem to have significant benefit. Thank you.
The expertise of all of us, including the patients, the nurses, etc., to look at ways to improve prognosis, decrease the toxicities, and it's through these small steps that we're going to get there. We're not there yet. We've got a lot to do. And we do have the energy and the collective energy to move on ahead. So with that, I'd like to invite any questions to any of the speakers, kindly. Any questions? Yes, please, sir. It's a Genentech compound. That's
It's a form of colon cancer and lung cancer in combination with cancer. Yeah.
any other questions? Okay. Oh, yes, sir. Yes, ma'am.
Mentioned significant delay in radiation therapy after glioma surgery. What is significant?
I can't remember the time frame for that study, but generally I know in our practice we try to start patients after resection for their malignant gliomas within 2 to 4 weeks. There's got to be that time when they need time to heal with their craniotomy incisions, but that would be standard. My assumption for that after, I know for the Turkish abstract was for patients generally beyond a month. There's always exceptions when sometimes you just have to, but we try to start patients within 2 to 4 weeks after their surgery.
So 4 weeks is okay.
Yeah.
Yes, ma'am.
Again,
Paul.
have there been any studies long-term done on children who were treated with radiation at, say, age 2, and then my son ended up getting glio-GBM, and they called it radiation-induced. So there has been many studies.
Yeah, there's a long literature history on looking at what we call second malignancies from radiation therapy. I think the original paper, I'm blanking on the author's name, but it was from like the 1940s or something like that. So there's been a lot of studies looking at that. Unfortunately, for a pediatric population, the rate of second malignancies can be quite high in some series. Very few series, but generally I think it can be as high as 10%, 1 in 10. Some series it's even higher, so it's unfortunately a high risk. For the adult series, it's much lower, thankfully. It's less than 1%. And we think for the pediatric population, one of the reasons it's so high is they're just developing. There's more risk of mutation as kind of their cells are developing.
Does that type of radiation use look different from a normal one, from one that was just diagnosed that way?
Well, yeah. I know from the data I know from the studies I've worked in, I haven't seen a difference. In fact, we even worked on a study looking at the supply very nicely, radiation-induced meningiomas, for example. And our results with radiation-induced meningiomas were the same as those that were just de novo primary meningiomas. So we did not see a difference.
The incidence that we're seeing, so you don't see a radiation-induced tumor for at least about 5 years. The issue is that it looks like the peak, it never actually plateaus, it just keeps going up. And so in some series, it's now up to 30% over a kind of 30-year period. About 80% of the tumors are benign meningiomas, and in fact, they usually don't require treatment, although if they keep popping up and pop up in an important area, you have to surgically resect them. If it ends up being a glioblastoma multiforme, because that part of the brain has already been radiated, that's what caused the radiation. The problem is you can't re-radiate without doing a lot more damage. And so now, since the major treatment for glioblastoma
pops up in the adult benign tumors, as Mark said, as a function of time, and it sets off the motion. So again, it's an issue of balancing the pluses of this modality. Like anything we do, surgery, chemotherapy, the biological therapies are also going to have it. There's going to be risk, benefit, and we have to weigh it out, systematically study, and get the best combination. Yes, yeah. Susan.
There's a lot of debate or discussion on how often someone with GBM with current treatment is going to learn. And we specifically know with two different great oncologists that have given different timelines with an active treatment path and then with their MRIs, there's a different timeframe.
So usually the scans are done right before you start treatment, and then evaluated usually every couple of cycles, usually cycles a month. So classically for the first year when you're on chemotherapy, we continue to assess whether the treatment is working, and also, of course, how the patient is doing on the treatment. So our scan and well is about every 2 months for the first year. If you're in a clinical trial, that might be different. So it depends on what treatment you're getting. For the Avastin or bevacizumab studies, most of those evaluations are done every 6 weeks because the infusion is done every 2 weeks. So it depends on the schedule of the drugs that your patients are on, and really usually about two months is about an average while on treatment. Yes?
I have a 20-year-old that his was originally diagnosed as meningitis, and 2 months later it was a grade 4 glioblastoma. And he's having the radiation chemotherapy together, 42 days of chemo, 30 days of radiation, and then we're going to wait 4 weeks before we look at scan the first scan. Is that
Yeah, so 2 to 4 weeks after the end of radiation is sort of standard because you want them to recover from the effects of the radiation and chemotherapy, and you want to be able to then evaluate what effect the treatments had. Actually, one of the other abstracts that were presented is this idea of what we call pseudo-progression now. So in other words, the MRI scan, as I mentioned, tells us very well about the structure, where things anatomically are in the brain. And it tells us about this disruption of the blood-brain barrier, which is this very tight junction between cells that prevents things from leaking into the brain. What happens when you do radiation and chemotherapy is that you can actually induce almost like an inflammatory response. So the scan that is obtained right after radiation, if you do it too soon, can be really hard to interpret. So in the past, we thought those were progression, but there was a very interesting paper where those patients, despite what the scan looked like, that looked worse, they carried on with the chemotherapy plan, and actually the next scan, in a number of patients, either got better or got stabilized. In other words, it wasn't that the tumor continued to grow, it was some other effect that was seen as a result of the treatment. So some of the things, we actually had a full workshop as to how better to understand the imaging, which is why I brought up the issues about some of these novel techniques, because the standard imaging, there are many limitations in what we can interpret in terms of, is it tumor that we're seeing or is it treatment effect? So the spectroscopy could be done. The key though is that like radio, looking at imaging, serial evaluation is important. So if you don't have a baseline and you just do a scan at one point, it's going to be very difficult. A lot of those novel techniques that are being looked at are research related, so they have to be validated. In other words, are they really telling us what we think they're telling us? And so a lot of the research is going into trying to validate what it is that we're seeing when we look at these images. So.
Okay. Yes, sir.
I'm in radiologist, but I'm also a pulmonologist in neuro-oncology. And one speaker mentioned the alphabet soup with the genetic traits and so forth that everybody, it seems like the much preferred. There's a lot of people in research and so forth
requires goal direction, an endpoint. But science also requires the ability to nurture ideas. And as we heard from a variety of speakers, brain tumors are not one entity. It's a variety of entities. And so you do have to have that balance that we need to study this in different aspects. An example is we need to look at how brain develops, normal development. Because remember, all of these genetic alterations, they are part and parcel of our normal regulatory controls. As Professor James talked about angiogenesis. Well, that's normal. We need blood vessels for a variety of physiological. So we need to understand normal as well, and then look at how those normal cues have gone aberrant in the tumor system. So in a society such as this, you need to be goal-directed, but you can't be restrictive. We don't have the answers. We have to apply the body of knowledge coming from different disciplines, different folks with different ideas, and apply that together. And of course, we learn from each other, because there may be something normal development or normal angiogenesis, which is very applicable to the tumor that we are interested in. So Susan has.
Yeah, I think discovery is really important, which is I think what you're seeing here is a lot of discovery, both in the basic science and in the clinic. But there are initiatives in terms of cooperative efforts that are within neuro-oncology. For example, the Specialized Program of Research Excellence is a translational program that's funded by the NIH, and there are now brain spores. And up until 5 years ago or so, there were no efforts in brain tumor patients to look at a translational effort. And what those types of cooperative efforts do is to bring these scientists together to talk about the research that they're doing and to look to see if there are common pathways. So there's always interaction that goes on. Similarly, there are national cooperative groups where a big question comes up, and the only way we can get those questions answered is for everybody to participate. So there are now international efforts to do the work as well as national efforts. And so I think that what you're saying is correct. We do need a consensus to move forward in different areas. But I think to limit what's happening in the lab, I think it would be a downside, because we need to learn as much as we can about neuroscience, about normal development, about stem cells. The stem cell information that we've been learning for this meeting, for example, has just been tremendous. So as we learn that, the question then is how do we best translate that efficiently to the patient? And that's where we have to get to. So better clinical trial design, participation, as Dr. Lang reached out to you. The only way we can really get to that point is for rigorous scientific questions that are asked in the clinic as well. And that's part of what the clinical aspect, which is clinical research, is really important for. And there are a lot of cooperative efforts to do that. So just to speak that.
A lot of things that we learn from an organism such as yeast, what's the connection with a yeast and a brain tumor? Well, a lot of the genes that are involved in cell cycle tells a cell to grow, be quiet. Well, those discoveries were from that yeast. And evolution has conserved many of those things. So learning from these various disciplines, I think, will get us there, and it should be encouraged. With, as Susan says, translation. Let's take that information towards brain tumors. So it's a balance. Okay. If there are no additional questions, first of all, I'd like to thank MGI for their support for this event. I'd like to also invite you to, there's some goodies and drinks available. Also, if you want to stay here or get your refreshments, we have a DVD that was prepared at the University of San Francisco, and we'll put this on. I don't know if the audio is going to work. You do? Excellent. Okay, so the audio is going to work. So we'll put this on. We're around. We do have our meeting banquet at around 7, so if we start to filter towards that, kind of excuses. But again, thank you very much. You folks have really started, I think, something worth
address some of the survivorship issues for patients. So actually, the impetus for this DVD was one as an educational tool for trainees. If you think about when we went to medical school, and I'll speak to the radiologist here, how much education did we really get about caregiving and how we handle the stresses that families go through? And specifically, of course, for the patient population, for brain tumor patients, what is it that we can do to help educate the needs and the resources that we might have available to help patients? So actually, I'm going to pass out also a questionnaire, because this is an educational tool. It is a questionnaire. You just fill out the first part, which is just about who you are, and you just say caregiver if you are, or patient, or if you're a clinician. And then after the viewing, there's some questions at the back as well that if you can answer. It's all anonymous, and this is part of us trying to improve upon the DVD and improve upon the delivery of this tool for both our patients, our caregivers, and as well as our students that we're trying to train with this. So thank you for staying. I'm just going to pass out these forms. Also, along with this, if I can have you take a look, we have this orientation to caregiving, a handbook that we've developed. And this is something that we're going to try to get distributed to every patient, every family with a brain tumor. And it's a resource that I think is really critical. It's one that I think that we in the society feel is important. And this is a reason to highlight the DVD as well. So we have one copy,